The concept of axis deviation is one that oftentimes goes over people's heads, or when it comes up in discussion, people tend to get that deer in the headlights look. While this certainly can be a complex topic in discussion, the basics of what it is, how we determine it, and what it all means is pretty straightforward. If it's explained properly, it should be pretty easy to understand this topic, so I'm going to attempt to do that in this lesson here. Alright, I welcome you guys back to another video lesson from ICU Advantage. For those of you who don't know me, my name is Eddie Watson, and my goal with this channel here is to try to give you guys the confidence to succeed in the ICU by taking these complex critical care subjects and making them easy to understand. I truly hope that I'm able to do just that. If I am, I do invite you to subscribe to the channel below. Make sure you hit that bell icon though, that way you never miss out when I release a new lesson. Now also, if you do enjoy these lessons and you'd be interested in getting CE credits for following along with them, then head on over to icuadvantage.com/academy and join the ICU Advantage Academy, where you can watch all these videos. You'll have access to all the notes, including the new notes that I'm currently working on updating, as well as audio-only versions of these lessons. And most importantly, you'll be able to actually earn CE credits for participating in this education. So I've got some great deals going on over there, so make sure and check that out. Now, if you would like to support the channel but really don't have a need for the CEs, or if you just want access to things like the notes, then you might also want to take a look at either the YouTube or Patreon memberships. Again, links to both of those. All that stuff is going to be down in the description below. So I'll start off things saying that as a bedside nurse in the ICU, it's certainly not going to be critical that you're able to take a 12-lead EKG and do the calculations to determine the cardiac axis. That said, it is important for you to understand what this all means, and more importantly, what physiological conditions would alter it. And truth be told, the process to roughly determine the cardiac axis on an EKG is pretty fast and easy, and it doesn't hurt to know how to do this pretty quickly. This is only going to give you a more intimate understanding of the EKG and allow you to confirm what the computer tells us on the paper. Before we get into determining these cardiac axes, let's actually review over some concepts that play an important role in this process. I did discuss these in previous lessons, but it'll be helpful to refresh that here and apply it to what we're doing. So first, we're going to be talking about vectors, aka the direction of electrical activity. So remember that if we have a positive electrode, that this is where we're looking from. Think of a camera that's on the positive electrode looking towards the negative electrode. If the electrical activity is moving directly towards this camera, aka positive lead, then we would see a completely positive waveform. On the flip side, if the electrical activity is moving directly away from our lead, then we're going to see a completely negative waveform. Now, if this electrical activity happens to move perfectly alongside or perpendicular to this lead, then we would see it going both towards and then away, giving us a waveform that is both positive and negative, and equally so. So these are the basic concepts of how these waveforms will look. But sometimes, in fact more often, the electrical activity is not going to be moving directly towards or directly away from a lead, but generally at some angle to it. So for example here, if we have it coming down towards the lead but off at a, let's say, 45-degree angle, we would see a mostly positive wave still, but we would also see some negative deflection to this waveform. The same goes if it's moving away at an angle. We are going to see mostly negative waveform, but with some positive direction as well. Alright, now let's talk about the cardiac axis and really what this means. So remember that when our heart depolarizes here, we have electrical activity that's taking place going in all sorts of different directions. So there's really millions of cardiac myocytes all facing in all sorts of directions. Some of them will be facing and thus depolarizing in the same direction, while others will be going in other directions. Our cardiac axis is the total average of all of these directions combined together. Remember that this is generally going from the patient's right arm to left leg direction or down into the patient's left. The left ventricle is by far the largest part of the heart, and thus, due to its size, it tends to overpower this average, which is why we see this as our normal. Now, later in this lesson, I will discuss this next concept here a bit more, but we have various pathologies that can cause this average direction of electrical activity to shift or deviate from this expected normal path. If someone has an enlarged heart or an enlarged ventricle, this can start to pull the electrical activity towards this larger area. If part of the heart has infarcted, then we would not see electrical activity in that area, and thus it would push or shift the direction away from this area. So changes in the function of the conduction system will also shift this direction depending on what's happening or if certain routes are blocked, such as with our bundle branch blocks that we just talked about. I am going to discuss these more in a later lesson, but just know that for various reasons, this cardiac axis isn't always going to be normal. And then finally, for our foundations here, let's talk about our limb leads. So conceptually, knowing the cardiac axis is the direction that we expect electrical activity to flow, how do we even determine this? Well, remember that we just discussed that we could determine what direction electrical activity is moving in relation to a positive electrode based on the morphology of the waveform. Thus, we can look at various leads, and knowing the directions that they're looking, as well as their morphology, that we can actually determine this. So to understand how we're going to do this in just a minute here, we need to also review over these leads real quickly. So for the purpose of this lesson, we're only going to be looking at the limb leads, so leads 1, 2, and 3, AVR, AVL, and AVF. So remember from that lesson a while ago that we're utilizing the right arm, and left leg electrodes to get these different limb lead views. So first, looking at leads 1, 2, and 3, we have the 3 electrodes that basically form a triangle on the body. While this isn't a perfect triangle, we actually have something that we call Einthoven's law, and again, this isn't important for you to memorize, but just good to know. But basically, this law says that we can think of this triangle actually as an electrically equal triangle. Thus, we can actually place these leads around our heart. And we know that lead 1 goes from right arm to left arm along the top here. Lead 2 goes from the right arm to the left leg along the side here. And lead 3 goes from the left arm to the left leg along the side here. Thus, these 3 leads are looking at the heart and its electrical activity in 3 different directions, which for simplicity's sake we can draw out here. Lead 1 is directly to the patient's left, while lead 2 is down and to the left, and then lead 3 is down and to the right. And again, that these are going towards the positive electrode, and therefore any electrical activity moving these directions would be positive. But we can also have this activity moving away, and so it could also be negative along the same line. And so for simplicity's sake, we can take a circle, divide it up into sections, with each of these sections being a direction that these leads are looking, such as positive lead 1, negative lead 1, positive lead 2, negative lead 2, positive lead 3, and negative lead 3. Alright, so now let's talk about AVR, AVL, and AVF. So these 3 limb leads basically are calculations that go from the middle of this triangle out to those respective electrodes. So to the right arm, we've got AVR, to the left arm, we've got AVL, and to the left leg, we've got AVF. So if we draw that out here, we can see that we again have 3 lines going out to a positive electrode like before, but now these are 3 more different directions. Again, this electrical activity can be moving either towards or positive, or away and negative, and thus we can also take these direction lines and use those to further divide up our circle that we just did with the other 3 leads. Alright, so now if we take this divided circle and take a closer look at it, we can set directions for all of these lines. So what this means is that we consider the positive direction of lead 1 to be 0 degrees. And if we move down, we have our positive degrees in 30-degree increments going all the way up to 180. Then moving along the top of the circle, we have our negative degrees, again in that 30-degree increment, going all the way to 180 degrees negative. So this divided circle here with these positive and negative directions of leads and the degrees of each line is something that we actually call the hexaxial reference system, And this is going to come into play here shortly in determining what our patient's cardiac axis is within 30 degrees. If you remember from before though, looking at this circle with the degrees, it kind of reminds us of the quadrants that I talked about. If we take a look at our 4 quadrants, we have this section being our normal axis, this here being our left axis deviation, this quadrant being the right axis deviation, and then this quadrant being our extreme axis deviation. We can then superimpose this over our hexaxial reference system, and remembering that I did mention that 0 to negative 30 degrees as being what we consider non-pathological left axis deviation, thus making it a part of our normal axis, we can now see how this hexaxial reference system can be used to determine not only the degree of our cardiac axis, but what we would consider it, whether it normal, left deviated, right deviated, or extreme deviation. Alright, so now on to our cardiac axis determination. So we've covered a lot of theory behind the concepts of the cardiac axis. This is important to help you understand what this all means and why it is that we're able to even know what the axis is. Now let's actually talk about the practical application of this hexaxial reference system and how we apply it to our 12-lead EKG. So we'll start out again with our normal EKG here. So the first step to this process is to take a look at our 6 limb leads, and we want to find the isoelectric lead. So we're looking for the lead that has the electrical activity that's moving alongside it or perpendicular to it, which is represented by that isoelectric waveform. So this lead isn't always going to be perfectly isoelectric. So it might be slightly more positive, slightly more negative, but of the 6 leads, it's typically going to be the smallest or the lowest voltage lead. You may have 2 leads that are close, but you want to make a determination of the most isoelectric. Again, also the smallest lead. So in our example with this EKG here, this is actually going to be AVL. And you can see that this one is pretty close to being perfectly isoelectric. It's pretty equal positive and negative, and it's definitely the lowest voltage. So then for step 2, now that we've identified the isoelectric lead, we then want to determine the perpendicular lead. So the perpendicular lead is going to be the lead that the electrical activity is mostly moving towards or away from. And this can be either positive or negative. Every lead has its own perpendicular lead, which conceptually, if we take a look at our hexaxial reference system, we can see that for each lead or line that's on here, there's another lead that intersects it perfectly perpendicular at 90 degrees. This is the perpendicular lead. So for our example here, if we look at AVL on our hexaxial reference system, let's highlight that in blue here. The perpendicular line to this is the one here in red, which is going to be lead 2. Now we can also just memorize this picture of our limb leads on an EKG with arrows showing the perpendicular leads. In the middle we have 2 in AVL going straight across. Then we do these diagonal lines for 1 in AVF being perpendicular and 3 in AVR being perpendicular. This is pretty easy to memorize and makes determining the perpendicular lead quick and easy. Again, following this method on our normal EKG, our isoelectric lead is AVL, and therefore we know straight across is our perpendicular lead, lead 2. Alright, for step 3, now that we know the perpendicular lead, we need to determine is the waveform in that lead positive or negative. Pretty simple, and in our example here we can see that we have a positive waveform in lead 2. Having this information, we then go back to our hexaxial reference system and look for the lead 2 line and go to the positive end. As we can see, this is going to be in the left inferior quadrant down here, and this is going to be at the 60-degree mark. We can also see that it's within the normal axis, which we'd expect with a normal EKG here. Again, we can compare this to the computer's interpretation, which has the QRS axis at 54 degrees, which is pretty darn close to what we just determined, so we also agree with it. Alright, so now let's talk about our left axis deviation. So this is going to be if we have an axis of negative 30 to negative 90 degrees. So remember that 0 to negative 30, while it is shifted leftward and considered a non-pathologic left axis deviation, we do consider this to be within the bounds of normal. Now with our left axis deviation, we have pathologies that are either pulling the electrical axis to the left, or other pathologies that are pushing the signal away from the right. So keep that in mind when we're looking at these potential causes of a left axis deviation. So we've got left bundle branch block, left anterior fascicular block can do this, left ventricle hypertrophy, so the enlarged ventricle is pulling at this point. If we have an inferior MI, we're losing that electrical signal over on the right, and it's going to be pushing or shifting it to the left. Ventricular ectopy, especially those originating in the left ventricle. Paced rhythms can look this way. Wolff-Parkinson's-White syndrome can do this, as well as any mechanical shift of the heart from a raised diaphragm. So here, think of things like our pregnancy, ascites, abdominal tumors, or even an enlarged liver or spleen. They're going to push up on that diaphragm and potentially shift and twist the heart. So let's look at a couple examples of a left axis deviation. So here is our first example here. Step 1, we want to isolate the isoelectric lead. So looking here, we can see that AVR is our isoelectric lead. So then we move on to step 2. This is going to be determining our perpendicular lead. So we can either reference that hexaxial chart, or using that picture from our memory, we know that lead 3 is going to be our perpendicular lead to AVR. And then on to step 3. When we look at lead 3, we see that it is negative. So when we go to our hexaxial reference chart, we can see that this puts us in the superior left at the negative 60 degree mark. Therefore, we know the axis is around negative 60 degrees, and it is in the pathological left axis deviation territory. For our next example here, let's go ahead and go through our steps. So step 1, here in this EKG, we can see that lead 2 is our isoelectric lead here. Moving on to step 2, from here, we're either going to be referencing, again, that hexaxial chart, or from our memory, we know the perpendicular lead to lead 2 is directly across here with AVL. And then for step 3, if we look at AVL, we see that this is positive, so we then go to our hexaxial chart. Positive AVL puts us at negative 30 degrees, which falls into the pathologic left axis deviation category, although just barely in this example. So now moving on to our right axis deviation. So this is now in the inferior right side of our quadrant, and this is going to be from 90 to 180 degrees. So we have pathologies that are either pulling the electrical activity to the right or shifting them from left to right. So examples here of some causes include things like the left posterior fascicular block. If we've got a lateral wall MI on the left, we're not going to have the electrical signal there causing it to be pushed or shift over to the right. A large right ventricular hypertrophy is going to be pulling the signal over that way. Same with a PE, especially with the enlarged right ventricle. COPD and emphysema, they can cause pressure that can cause the heart to sort of twist and shift. Ventricular ectopy, again, this time originating in that right ventricle. Hyperkalemia, as well as sodium channel blocker toxicity can cause this. Again, Wolff-Parkinson-White syndrome, as well as this is also normal in people who have a horizontally positioned heart. All right, now for some examples of right axis deviation. Here's the first example here. So we're going to go through this pretty quickly here. Step 1, we can see our isoelectric lead is going to be lead 2 in this example. So step 2, either referencing our chart or from our memory, we know that the perpendicular lead to lead 2 is directly across an AVL. And then for step 3, we see AVL is negative now, so going to our hexaxial reference chart, we know that we're in the inferior right quadrant with an axis of 150 degrees, making this a right axis deviation. All right, in this next example here, step 1, this one's a little harder to tell, but AVR appears to be the smallest and the most isoelectric lead. Step 2, we can then determine our perpendicular lead, again, hexaxial chart or from memory, giving us lead 3 as our perpendicular lead here. For step 3, we see that lead 3 is positive, so we again go to our hexaxial reference chart. We see, again, inferior right quadrant with an axis of 120 degrees this time, still giving us right axis deviation. And then now finally for our extreme axis deviation, this is something that's also referred to as a northwest axis, and this is certainly not a common one. So our extreme axis deviation is going to be now in that superior right quadrant and goes from our negative 90 to negative 180 degrees. Some potential causes of this can include things like having our electrodes misplaced, particularly our right arm and left arm electrodes being reversed or flipped. Ventricular rhythms such as VTAC, idioventricular rhythm, ventricular escape rhythms. If these are originating in the apex of the left ventricle, that signal is now moving in the opposite direction from what we would normally expect, and that can cause extreme axis deviation. Extreme hyperkalemia can cause this. Severe COPD or emphysema can also cause this, as well as ventricular pacing. Specifically, we've got the stimulation that's either in the apex of the right ventricle or left ventricle. All right, and then an example of extreme axis deviation, we've got one for you here. Step 1, again, this one's kind of hard to tell, but lead 3 appears to be the smallest and most isoelectric here. So for step 2, we determine that AVR is our perpendicular lead here. And then for step 3, AVR is positive, so if we go to the hexaxial reference, we can see that we are now in the superior right quadrant with an axis of negative 150, putting us into the extreme axis deviation territory. All right, and so that is the gist, the basics of cardiac axis determination. So like I said, it's really not that difficult of a thing to do, especially once you have that hexaxial reference chart to use in this. And really just going through 3 easy steps, looking at your 6 limb leads on your EKG, you can pretty quickly come up with a very close approximation of the degree of the cardiac axis, as well as knowing where that falls in our pathologies, whether that's normal, left or right deviated, or an extreme deviation. So I really hope this lesson serves as a foundation for you guys and gives you a little better understanding of what the heck we're even talking about when we're discussing the cardiac axis. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.